Thanks for joining us tonight. My name is Ridita, and I am the account manager at TOEFX. I take care of the Canadian and US customer accounts. And tonight we have our speaker, Dr. Tracey Vlahovic, with us. And Dr. Tracey Vlahovic is a professor at Samuel Merritt University College of Podiatric Medicine in Oakland, California, with more than 20 years of experience in academic podiatric medicine, clinical research, and patient care. She was the first podiatric physician to complete a fellowship in podiatric dermatology and has made significant contributions to the field through her extensive clinical and academic work. Dr. Vlahovic has conducted and participated in numerous clinical trials, published extensively in peer-reviewed journal, and authored several textbooks. Her expertise spans podiatric dermatology, clinical education, research, and patient care, making her a respected educator, clinician, and a leader in podiatric medicine. We also have Dr. Edith Van Ham with us. So, Dr. Van Ham, the floor is yours.
I was muted. Thanks, Radita. So again, Dr. Vlahovic, I'm always so excited that we have you speaking about interesting topics. We are the host, TOEFX is the host of this webinar, so I would love to tell you a few things about TOEFX and myself. So I'm a toxicologist by trade, and in TOEFX I'm the Chief Technology Officer, so I'm in charge of new development of new products, commercialization, and training. And I was also heavily involved in designing the clinical studies. Let me share my screen for a second. So just a little bit about us, if there are in the audience clinicians that do not know us yet. So we are a complete business unit, end-to-end care for onychomycosis. So we do offer a treatment. It's photodisinfection or photodynamic therapy. So we created a cutting edge also diagnostics for onychomycosis, because throughout the clinical study we realized that we really don't have a good way to confirm the diagnostics. So we have a very cool and accurate PCR. I wanted to tell you a little bit about our technology. So while you have orals, topicals, and lasers, I wanted just to emphasize between the innovative TOEFX technology and laser. While both of them are light therapy, TOEFX is photodynamic therapy, so it comprises of a light, not a laser, that works together with a photosensitizer. The photosensitizer, the way I like to describe it, it's like an enhancement. It's like the gel of the ultrasound. Dr. Vlahovic, I'm not sure if you like the analogy, but this is, I think, a cool way to explain. So as the gel of the ultrasound enhances the sound, so the photosensitizer enhances the energy of the light. The light looks like that. It has dual wavelengths light, red, which is 660 nanometer, and blue, which is 405. They work together. There is a footrest where the patient sits under the light. All 5 toenails are exposed at the same time. And the protocol is filing down the nails, applying the photosensitizer, and then they sit under the light for only 12 minutes. Just briefly about the mode of action, and here you can see some before and after. So assuming that this is a confirmed case of onychomycosis, you have oxygen, ambient oxygen around the tissue, as every living organism should have oxygen around it. And once you apply the serum, it penetrates predominantly to the infection, because there is a high affinity between this liquid and infections. It can be dermatophyte, candida, aspergillus, bacteria, it doesn't matter. And it sits in the wall of the microorganism. And once you shine the light, the photosensitizer taking the energy of the light and transfer it to ambient oxygen and make it reactive oxygen. And this reactive oxygen is like a very nervous molecule, and it's destroying everything around it. There is no pain and no burning sensation associated with it in comparison to laser. So this is another way to look at the mode of action. You can see here how the dye adheres very well to the infection. So this is before, and this is 2 weeks later. So you can see that it's marking down the infection. We published and got accepted to the Journal of the APMA a few months ago. We did a study where we looked at 165 severe cases of mostly severe cases of onychomycosis, and we found the technology to be 70% effective and 100% selective. So if you want to learn more, we are here, Redita and myself. I'm happy to answer any questions after the webinar, or feel free to send us emails. So without further ado, I would like to give the floor to Dr. Vlahovic.
Thank you so much. All right, let me share my screen. Okay. All right, excellent. I do like the analogy of the ultrasound gel. It makes sense to me. All right, so tonight, talking about biomechanical to nail disease to onychomycosis. So I'm going to cover a lot. Let's begin with talking about pincer nails. And I remember when I was a young podiatrist, pincer nails, I was like, oh. But as time went on, I still find them fascinating. And once I really started diving deep into them, I wasn't afraid of them anymore. They were first described formally in 1968. Of course, they've been around a lot longer than that. We classically think of it as the great toenail, but obviously any toenail can be involved. In some cases, it's an enlarged base of the distal phalanx, and you get these traction osteophytes on the collateral ligaments. You can either be born with this or it can be acquired. It's not the same thing as an ingrown toenail, but as we know, some of our patients who have this have extreme pain in their nail borders. Patients are coming to us because it's either cosmetic or because it's painful. Oh, sorry. Sometimes when you're on Zoom, the PowerPoint gets a little funky. So what really made me fascinated about pincer nails is this term called mechanobiology. And what this means is that physical forces affect our skin. We are already familiar with this. We just didn't have a name for it. Every time we look at somebody who has a callus that's biomechanically induced, that's mechanobiology. Well, pincer nails are the same way. Pincer nails, the theory is that you have this constant ground reaction force every time you take a step. And you have a natural curvature of the nail. So every time you take that step, you get that ground reaction force that kind of equals out the natural curvature of your nail. Well, when we don't have as much of that ground reaction force, meaning maybe a patient is bedbound, they're wheelchair bound, they're no longer ambulatory, you're lacking that ground reaction force, and the nail then, its natural curvature can be pretty extreme. So that imbalance is one of the ways we can see pincer nails. Now, obviously, that's not every single patient we see, but it makes sense that when I was a resident, and even as a podiatric medical student, why I would see a preponderance of this when I would have my certain rotations, certain patients, that these existed. And patients would say, I didn't have this before. My nails didn't look like this before. Well, that kind of makes sense. There are other reasons we can develop pincer nails. Onychomycosis, of course, can reshape the nail, as can psoriasis. But interestingly enough, beta blockers, sorry that I have that twice there, I just saw that in the slide. Beta blockers, the medication, and even ALS. And ALS, if you think about it, you're at one point non-ambulatory, but also your fingers aren't getting the motion that they need. So we can see that pincer nails, even in fingernails. Lupus can cause a Kawasaki's disease, and AVF for hemodialysis. So there's a lot of reasons that we can see these nail changes. So we always want to start out with conservative therapies. And of course, we can simply trim or debride these nails. I mean, that's something that all of us have done. One thing that I have tried is to do bracing. And I know that some people in our profession will do other kinds of bracing. There's, a certain brand name that many people will use. The problem is that the bracing isn't a long-term solution. It'll temporarily reshape the nail, but the long-term data isn't great. And I have to be honest with you, when I did the plastic bracing, I had such a struggle to get one side down and then get the other side glued down and have it stay. So it was for me, with the brand I was using, was really frustrating. Over in Asia, they have nail steel bracing, which I have tried desperately to get here. It was a very specific kind of thermoelastic steel, and I couldn't get it, but it was really interesting. We can also do other things like taping and splinting. Again, these are temporary things, trying to take advantage of the elasticity of the nail unit. But again, things we can do. Topicals, like using the urea occlusion method, which is where you take urea 40% cream, you apply it under occlusion like moleskin or a Band-Aid every day for 7 to 10 days. It just kind of dissolves the nail. So for our patients with vascular embarrassment, not a bad idea if they can't really undergo any kind of procedure. But again, the recurrence is really high with these conservative therapies because we're not addressing the underlying deformity. So there's some other interesting conservative therapies that have come out since that original sort of statement. And this one I have actually tried. Tazarotene 0.1% gel. Tazarotene is the strongest retinoid we have. Commonly, we use it for psoriasis or acne. It's very, very strong. It can be really irritating. So this is a case report. So again, it doesn't have the highest level of evidence, but it's compelling. 35-year-old had her left hallux involved. That's obviously her left hallux. She used it on the nail twice a day for 5 months, and you can see the result. It's actually really interesting. Now, retinoids are changing like the cellular proliferation. The problem with this case report is, yeah, we have a lovely end result, but we don't know what the long-term effects are. So again, something nice to be able to use from a conservative standpoint, with the caution of there could be recurrence. I have also used the YAG laser. This was also a case report, using it on a female who had both her hallux nails involved. They used the long pulse 1064 nanometer ND YAG with a spot size of 4 millimeters, fluence about anywhere between 34 to 46 joules per centimeter squared for 2 passes. Now, depending on the laser you have, you can't extrapolate these parameters. Like that's the problem from laser to laser. It's very, very different from company to company. So take this with a grain of salt. They did this once a month for 4 months. Again, had a good result. No long-term follow-up with this particular patient. This is something that I think many of us could get our heads around because we all suture. We all have been suturing a very long time. And this is basically just taking a needle and like boring like 2 little holes in the nail. And they used silk suture, which is really interesting. Number 1, silk suture. And they basically just took the suture and then like used it to bring the sides of the nail plate up. And they removed that after 6 weeks of wearing it. The height did decrease. Again, no long-term follow-up, but for some patients, this might be a perfectly fine option, saying, well, we can do this every once in a while. No harm, no foul, right? If you can tolerate it, great. Obviously, if they're very hard on their feet, if it tears because of shoe donning and doffing and things like that, then, it's not the best solution, but it's something. It's always good to have many things, many tricks up your sleeve. If you are friends or related or married to an orthodontist, this could be for you. So this is where they're using dental correction principles. They took 99 toenails, which reminds me of that old song, 99 Red Balloons from when I was a youth. And they used it on 68 patients. They use this nickel titanium super elastic wire. And those of us who've had braces, this girl twice, um, know what this feels like. So they basically bonded this arch wire to a resin on the nail, followed it up in 4 weeks, and they looked at pain score and the height to width ratio. And you can see, again, there was a decrease. This to me is very similar to what we would see with the nail metal wire or the plastic bracing. So again, not a great long-term situation, but something that's temporary. And I mean, as you can see in these pictures, it did decrease the height and the width quite well, but again, more of a temporary solution. So, what is more of a long term solution? Well, surgery, but that's not for everybody, right? So, it's nice to have tools in our toolbox. This is going to target the underlying deformity if that's present. And for me, sometimes that could be a subungual exostosis. It could be, again, some thickening of the distal phalanx base. So, it just really depends. What I do caution people against is removing the toenail totally. I've you'll see later in this lecture why I'm not for a total nail avulsion to solve these problems. Thinking it'll come in differently. There's a sequela to that, and it's something I'm always thinking about. So we can do something like this, and I will show you. This is the method that I have done my entire career. This is called the zigzag because it looks like a zigzag, but to me it looks like an M or a W, depending on your perspective, right? Tomato, tomato. So basically here, in this case, they did remove the nail to have access and visualization of the distal phalanx. They are retracting it back, and you can see that they're using a surgical burr, and they're just flattening that the bone down, and then taking that tissue and pulling it out and forward, because you have a lot of excess tissue with these pincer nails. So you have to flatten that tissue to encourage the nail that's subsequently going to grow out, if you have to remove the nail, to grow out in a certain pattern. So this is, you can see that that tissue again has been pulled out laterally and medially and distal. Then the nail comes in flat. This is again what I have done. I've seen lovely success with this. There is another way of doing this, but this is the one to me that's consistently that I've gotten results from and the easiest for me. Anyway, this is one of my patients. So you can see we have some excess tissue at the distal tuft. Here's the pincer nail. Not liking it. Again, I don't like to remove the nail if I don't have to, but I did in order to, again, visualize the bone during the procedure. And then this is the suturing afterwards. So what I end up doing with these patients is using Aquaphor or some other kind of ointment to keep that nail bed moist so it doesn't dry out. This is just an example. This was a patient. I'll never forget her. Like there are patients in our career that you never forget them because of what they say, of just, and the funny things that they say or how they say it. And it makes me smile internally. And this patient was like, "Doc, if you don't remove my toenail today, I'm going to take it off with my teeth." And I was like, "Nope, not going to let you do that," because I believe her. Maybe she wouldn't have been able to actually take it off with her teeth, but she would have found a way. So this was her x-ray. You can see that spike, that beautiful spike going across the distal phalanx with that collimated radiograph. And I always recommend when you have a pincer nail that's really painful, get a collimated radiograph or isolated where they are able to look at it you're able to look at it the lateral view, and they're isolating it so that you don't get superimposition with the other toes. So, this was her toe and this was the nail subsequently. And patients always ask to keep it. I'm like, you don't want to keep this, right? I don't know if that's happened to you, but it's definitely happened to me, right? I think it's more when you remove like a screw, once, when they've had hardware put in. I don't know. It's just one of those things. So next disease state is a patient. This is so common. Oh my goodness. If I don't have a week where I see this, like it feels unnatural. This is a patient who complains of having an ingrown toenail at the tip of the toe. not on the sides, but the tip. And has had multiple nail avulsions from multiple doctors to treat the nail fungus that never seems to solve the problem. And the length of this left hallux nail is not the same length as on the right. And that's really bothersome cosmetically to the patient. So let me show you what that looks like. I know the lighting is weird here. I promise you it's the same patient. But sometimes, the lighting in our rooms can be a little funky with our phones. So this is the right foot and this is the left. And you can see that there looks like there's some subungual debris. There's some discoloration. That nail looks like fungus, right? But it's not. It's actually not. When we do our physical exam and get some lab results, there's pain on palpation at the distal tip of the nail. We've all been there like, yeah, that hurts right there. But there's no pain on palpation on the sides. There's no drainage, there's no edema, and it's just you get that distal hypertrophy that you can see of the tip of the hallux, okay? The pulp of the hallux. I had a microscope in my office. Yes, I am that kind of a nerd, and I could do an in-office KOH. I know that is not what everybody does. That's okay. That's my jam, my toe jam. Sorry, bad pun. There was no hyphae present. So what's next? All right, we get an x-ray. Told you, get a radiograph, and you get it collimated to the great toe so we don't get superimposition. Look at that gorgeous nail silhouette, right? Like you're just like, boom, that's your nail. And we look at the distal phalanx. Phalanx looks completely fine, but I always like to rule out any kind of subungual exostosis. And the next case of this is, again, I don't know how many times I've had this where a teenager comes in, prom's coming up, they're going on a cruise, graduation's coming up, something's happening, and they're just like, the nail will only grow so far and it falls off. And that's the complaint, right? And they're just distraught because they want to wear cute shoes to prom or sandals on their cruise. So you can see what the nail looks like, okay? And it's just not a healthy looking nail. You see that distal hypertrophy of the pulp of the toe, just not cute. These two cases are disappearing nail bed. I am extremely passionate about disappearing nail bed, and I know that is weird. I know it's strange. But the problem is that in the beginning of my career, I remember having patients like this, and they would say, why isn't this going away? Why can't you fix it? I'd like, I've tested it for fungus. It's not fungus. I did do a total nail avulsion. It didn't get better. I didn't understand it until in 2005. So I was only in practice for like 2 years at that point. I went to a lecture by Dr. Ralph Daniel, who's a dermatologist in Mississippi. He's an awesome man, awesome doctor. He coined this phrase. And it was like the world opened up and heavenly music surrounded me because I was like, I've seen this and I just didn't know. So what this is where the nail bed upon exposure to air, do not know the length of time. Nobody knows the length of time. That when the nail bed is exposed to air, the nail bed changes. It literally disappears. It becomes epithelialized like the pulp of your toe. We get dermatoglyphics appearing, and we actually get a new layer that wasn't in your nail bed before. So there's a physiologic change. When you don't have that nail bed anymore, the nail cannot slip over it. It's like when Brad Pitt and Angelina Jolie were getting divorced and were living in the same mansion, I think in France, something like that. They were living in two different wings of their mansion. I was like, it's like you're divorced, but you're still living together, but you're just not interacting at all. That's what the nail plate and the lack of nail bed kind of remind me of. So we can see this on any nail, whether it's a fingernail or a toenail. Like if you think about somebody who maybe sucks their thumb or has lost their nail, that this has happened. But obviously toenails are the biggest place. The hallux, at least absolutely with my career, hallux is the place I've seen it the most, but it can happen anywhere. So what is the source of that long-standing onycholysis where the nail bed is exposed to air? Number one, onychomycosis. Number two, onychogryphosis or ram's horns nails. Absolutely. Seen that over and over again. But trauma, whether it's something that was repetitive trauma from their activity or their shoes or blunt trauma. Nail surgery, we've removed the nail. biomechanics like a hallux extensus, and other disorders that cause onycholysis like psoriasis, like planus, and even other medications. But always rule out a bony deformity for it first. So why does this happen? Again, we do not know the length of time for that onycholysis to be present for this to occur, but nail bed, normal nail bed, doesn't have the granular layer of the epithelium. So, in our epidermis, we have our layer, our basal layer, and all the layers that go up to the stratum corneum. Well, it's lacking a granular layer. And and the nail plate technically is the stratum corneum, if you want to think about like that being the how the epidermis is, right? So there is no granular layer. And for whatever reason, when you don't have the nail plate covering the nail bed, the granular layer appears. And that skin has memory, and it becomes like a regular fingerprint memory. The nail plate can no longer slide across the nail bed, and you get that hypertrophy of the distal pulp, which causes that nail to abut against it. And the nail cannot grow forward, and you get that distal ingrown nail. It's a real not pleasant thing for the patient. So the distal pulp of the tail of the toe deforms, creating a physical barrier for the nail to grow forward. Again, we do not know the length of time. That would be really difficult to study because you don't want to cause this in somebody. And, I think the only way you could maybe look at it is somebody who's had a traumatic nail avulsion and follow them along if you can even do that. But that's challenging, right? Like trying to have our own patients follow up with us sometimes is challenging. In the beginning of my career, when I did a total nail avulsion on these patients, before I knew any better, I noticed right away that when I did that total nail avulsion, that the nail matrix was really atrophied. I was like, this is really strange. Why is this happening? Now I get it, right? If the nail plate can't grow forward, it's not achieving its maximum length, well, the nail matrix is going to atrophy. So it makes sense. So what are our options? Please don't do a total nail avulsion to fix this. Don't do what I did, okay? You have to be honest with the patient in the most diplomatic way, saying, once you have that nail bed exposed and it becomes skin, it's irreversible. But sometimes I have found that patients, when they hear that, it's reassuring or comforting. Like it's not anything that you did, it's physiology, right? It's just what happens. And if we can get the nail plate to grow forward, in some cases, you're going to see what you're seeing here, which is a cavern. You just have to keep it clean. And we just have to set realistic expectations with the patient. So what are our choices to manage? You can see in this picture, I taped the patient. So taping the tissue, I used Omnifix tape here, don't work for them. I just that's the tape we had and I really liked it. It's very flexible and stays on with water to a certain extent. That's just trying to deform that distal pulp so that the distal pulp can flatten and the nail plate can grow forward. We can treat the ingrown nail if it's present, and that can happen. If patients don't want to do anything and they just want an appearance of a pretty nail, we can apply Cariflex as long as there's 10% of the nail plate present. They can wear shoes that accommodate their deformity, right? Or insoles if they've got any kind of biomechanical issue. And if there is actually a fungus there, well, we can treat the dermatophyte. But again, set realistic expectations about what the look of the nail is going to be long term. So this is a taping method that I learned from a Japanese dermatologist many, many, many years ago. Patients have to be consistent and do it for months. This will not cure anything or treat anything within a week, a day, a month. It takes months. So patients have to be patient to do that and motivated. And sometimes people just aren't. And I get that, right? Like you have to apply it and you have to be diligent about doing it. So for those patients who are motivated, they'll happily do it. And they might come to you in 2 months and say, is it better yet? And you're like, it's getting there. It just takes a long time for this to change. So you have to be really reassuring. Cariflex, this is from their website, but this is a typical patient that would come in and they're just like, I don't want to do anything. Just make it look nice. All right. Just want to go to a, soiree and wear open-toed shoes. and I get it. But this is a procedure that I have done. It's called the Howard Dubois procedure. This was a patient who was hiking, had a bad injury during hiking to the nail, and the nail just didn't recover. So developed the distal embedding. And that's what this is happening. That's that ingrown nail that's distally happening. So we treat the distal embedding. I curette all of that. And then just do a small skin plasty to help push that skin forward, distal and up and flat. So again, the nail has a chance to grow flat and forward. That's our whole goal. Again, I cannot make that nail bed come back. I absolutely cannot. You can't, please don't tell me that you're going to curette it and do all those things. It is a physiologic change that curetting will not make come back. The nail bed is very, very specific in its physiology. So another biomechanical issue is retronychian onychomycosis. If I don't see this every week, then again, it feels like an abnormal week. I love this. I don't know why. Again, very weird person, but this is where you've had trauma that's pushed the nail back into the proximal nail fold. And that trauma, I recently had a patient who was ice hiking. It blows my mind. So she was digging her spikes into the side of the mountain and got a terrible case of this. But I've also seen this, like this case, what you're looking at was a patient who had ill-fitting insoles that she'd gotten from another practitioner and developed it on both hallux nails again because it was too tight in her shoes. It wasn't fitting her properly. So there's a lot of reasons that we can get that trauma. It could be, again, mechanical, it could be physical, it could be something, right? So what happens is that the nail matrix is always producing nail plate, always, always, always. So when you have nail plate that's already produced getting pushed back into the matrix, the nail matrix is like, okay, just going to work around it. It just keeps on going. And so if that is a once and done trauma, then you will have new nail plate underneath that pushed back nail plate. That pushed back nail plate is called retronychia. And when the two nail plates are growing out, you have the new nail plate and the old nail plate on top of it. That's called onychomycosis. Now, in certain situations, you could have 2 or 3 or even 4 nails if there's chronic repetitive trauma. Like I tend to think of like a ballet dancer on point. That's chronic repetitive trauma being literally on your toes. So I want you to take a look at this because I know that you have all seen this. So this is the old nail plate. I'm outlining it with my mouse. This is the old nail plate. This is the old nail plate. This is the new nail plate underneath. And obviously this is really visually clear. Sometimes it isn't. And you just see like a little sliver of that new nail plate underneath at the cuticle. So if a patient is going to allow me to do it, I will Dremel the whole old nail plate off. And I'll say to them, you have nail plate underneath. You just can't see it. And it's also, patients will swear to you up and down that they have nail fungus. I'm like, it's most likely not nail fungus. I mean, sure, there could be an element of nail fungus there. You'd have to certainly do more testing. But a lot of times, nail plate on nail plate creates this yellow opaque discoloration. So this is a good reason why we like to do testing to make sure something's onychomycosis, because all I had to do was just Dremel off that old nail plate and voila. You know, that discoloration's changed. The nail looks rough because I just Dremeled it, but that is showing the patient, look, you have new nail plate underneath that, again, you had trauma. So the question is, can you determine the diagnosis based on the visual information? Well, you know, a lot of us, again, those of us have been in practice for a while. I've been in practice for a while, over 23 years. Is that possible? Right? Like when you sit and think about how long you've been in practice, you're like, how did that happen? You know, I know that in the beginning of my career is like, yeah, that's fungus. But the reality is that as you get older and wiser and have more perspective, and then you just see more things, you realize you can't tell visually, right? You have an idea, you have a really good idea, but you have to do diagnostic testing to really make sure. So these two patients do not have fungus. This is a patient of mine who had pustular psoriasis underneath her nails, which made her nails discolored. This patient had lichen planus. So rough nails, discolored nails, got to make sure you know what you're looking at. So in order to look at this a little bit more, now it's been a while since I've ordered KOH and culture. I kind of prefer PAS and GMS, and some of you might do PCR testing, depending on what your flavor is. But they took a look at some nails and said, okay, out of these 60 patients, 22 were KOH positive. And out of these 60 patients, 35 had psoriasis, 20 had onychomycosis, and 15 had nail trauma. And then they looked at it using a dermatoscope. And I use this with my dermatoscope all the time. So when I see these sort of jagged onycholytic edges, that's onychomycosis. But when I see a really even onycholysis at the edge, that is trauma. And if I see a lot of redness and things like that, then I usually think of psoriasis. So that helps me be a little bit more visually clear, until I get the, testing back, the diagnostic testing back. So I can use my dermatoscope to a certain extent. So same thing here. This is onychomycosis. This discoloration around the onycholysis is psoriasis because it's an inflammatory skin disease. And this even onycholysis that we're seeing up close with the dermatoscope, that's trauma. And seen that so many times, whether it's on a lesser digit because of a hammer toe or again, a hallux. But, let's get back to basics. Like, how does fungus even cause onychomycosis, right? How does it even take hold? Well, you need exposure to the dermatophyte, and that could be tinea. How many of us have had patients where they don't have tinea and they had traumatic implantation because of a pedicure, right? Patients will always ask me that, like, my feet are clean. Like, it has nothing to do with hygiene. It just happens. Like, there is a genetic component to it for some patients, but also, again, implantation from the client before them in a pedicure where the instruments were not sterilized. Trauma to the hyponychium, that happens in a pedicure too, or cutting the nail too close. Trauma, like a steel-toed boot, or from another skin condition like psoriasis causes trauma to the nail, to the hyponychium, which is the distal tip. The dermatophyte is, I always say, a greedy little bugger. It just wants keratin, right? It's hungry for keratin. That's its life source, right? And it uses the keratinase enzyme to digest it, which remarkably so causes mild inflammation, changes the pH of the nail unit, which then shuts off the skin's immune system, right? Remember from high school and college chemistry, if you don't have your pH, if you don't have your enzymes, if you don't have like the whole perfect sort of chemical reaction or physical reaction, it's not going to happen. So if your pH is off, things aren't going to happen, right? So the immune system's like, who cares? Invaders, who cares, right? So that's why onychomycosis is an infection that hangs on. It's not going anywhere unless we do something to it. And that sadly makes it to people feel like it's not a very important infection, right? And I get that if you're a non-podiatric physician, a non-dermatologist, but for those of us who do what we do, we know this is an infection, right? It may not be a pus bump, it may not be a sore throat. I get that, but it's still an infection, right? So what happens is that dermatophyte just is like having the time of its life. It's at the biggest Vegas buffet you can imagine, and it gets greedy, right? So it's going to go into the lamina of the nail plate. So it starts out in the nail bed and goes into the lamina of the nail plate and makes that nail plate brittle. Okay. And that compromised hyponychium then creates a reservoir and basically what I like to call a fungal party, which is the best kind of party. You've got molds, you've got bacteria, you've got fungus all hanging out, really, really happy. And that's where our biofilm comes in, right? So how do you treat this? Well, there was a paper that I was involved with. It was one of the happiest days of my life because I got to talk to other dermatologists on Zoom. It was during the pandemic. We just talked for like 6 hours, and you're like, this is why you have no friends, Tracey, because you can talk about nails for 6 hours. So we talked about how do we treat nails, and obviously pregnant lactating patients, we don't have specific recommendations. I always recommend you talk to their OB. With pediatrics, well, we FDA approval, we have efinaconazole, tavabril, and ciclopirox. Ciclopirox is for 12 and up. Efinaconazole and tavabril are for 6 and up. But for adults, we're kind of striating it into saying, well, is it mild, moderate, severe? Is there a dermatophytoma, which is a fungal streak, like a fungal ball? And what is the patient's characteristics, right? Are they on a lot of other medications? Do they have nail psoriasis? Do they have any liver or kidney issues? Are they diabetic, immunocompromised, can't take an oral medication? Like, what else is going on? What's our treatment theme, right? And to make this a little bit even more interesting, with onychomycosis, we know that our diabetic patients are almost 3 times more likely to have onychomycosis. There's a lot going on with our diabetic patients. There's the metabolic syndrome and things like that. So there's a predisposition to developing these fungal infections. What about psoriasis patients? You might say, Tracey, I don't see psoriasis patients. I bet you do. But this was a 13 studies that looked at 2,700 psoriasis patients and 10,000 non-psoriasis patients. And through those studies, psoriasis patients had a significantly higher prevalence of onychomycosis than those who didn't have psoriasis, almost 2 times more likely. So what this paper ended up saying is that psoriasis is an independent risk factor to develop onychomycosis. That psoriasis increases patient susceptibility. Why? Because psoriasis, in some cases, can cause onycholysis of that hyponychium, which allows the dermatophytes, those greedy little buggers, to go in and get as much keratin from that vagus buffet underneath your nail. The other thing is that we can see if there's any digital abnormalities like hammer toes and things like that. We can see the nail get chronic repetitive trauma, and that causes the Kebner phenomenon with nail psoriasis. So these patients, again, are predisposed. And it's a population we didn't really talk about before. So if you have a patient comes in who says, I've got scalp psoriasis. Okay, they've got maybe psoriasis just on their elbows. Well, take a look at their nails, because they might have onychomycosis, very possibly. They could have nail psoriasis, or they could have both. And that was the hindrance with this paper, is that they actually didn't address that you can have both onychomycosis and nail psoriasis going on in the same nail, to blow your mind. So that's called secondary onychomycosis. But again, this serves to me as saying, you know what, if I have a psoriasis patient, I've really got to consider that they might actually have onychomycosis. So we talked about that there's topical therapies, there's oral therapies, and there's laser, but there's something called photodynamic therapy. I was introduced to photodynamic therapy very long time ago during my dermatology fellowship. We were always talking about it for actinic keratoses, and that's where I would see it utilized. And many, many, many years ago, I was at the World Congress of Podiatry, and I forget which country, but it was somewhere in Europe. And they were talking about photodynamic therapy for onychomycosis back then. And I always thought, well, that's fascinating. I always thought about it for actinic keratosis. And I always thought about, well, we use the Levulan keratostic or aminolevulinic acid for actinic keratosis. How would that work for a nail? Well, and this is what this is talking about. So what photodynamic therapy is using a photosensitizer. So some chemical compound that's going to make the tissue susceptible or reactive to the light, right? You need a light source of a specific wavelength, could be a laser or not a laser, and then oxygen in the tissue. Because ultimately, like she had said, you're going to have reactive oxygen species. And that is, while that photosensitizer and that light is combined, you're getting those reactive oxygen species. When you turn that light source off, the reaction stops. This was the first drug device combination approved by the FDA, and it's non-invasive. So for our patients who are like, I don't want to take anything, I don't want to paint anything on, I don't want to think about it, right? This is something that they can come in the office and get. So this is a schematic of what it looks like, right? You have your funky toenail. You have a photosensitizer that's applied, you have a light source, and while that concomitantly is happening, you get your reactive oxygen species, which helps kill your microorganisms and ultimately an antifungal effect. So this is the paper that's currently in press that should be hopefully published soon. It's 165 great toenails treated in 101 patients. These patients had dermatophytomas. If you remember a couple slides ago in that algorithm I showed you, dermatophytomas are these fungal streaks. You've all seen them, but in dermatology, that's what their name is. We in podiatry don't talk about it very much, but they're yellow streaks. So they included those. They included patients who had total nail dystrophy, patients who had severe presentation, which are often excluded. I can honestly say that from clinical trials. They used a methylene blue product, like a methyl, it's very hard for me to say that because it's a tongue twister, and a plant-based extract. And they used a LED light source that was applied for either 12 or 15 minutes. They did this every 2 weeks for 6 months. And they measured the success by greater than or equal to 3 millimeters growth or total clearance, of which they achieved that in 120 out of 165 nails. And out of the nails that had total clearance were 88 out of 165. The mycological cure, which is, measured by did you eradicate the fungus completely, which, in all of our studies is never, it's never 100%. We know that in with terbinafine, it's 70, with itraconazole 67. Here it was 59%. So again, nails that were, some of these were very severe nails. So you have to think about, like, it's pretty impressive, right? Nails with severe presentation that were heavily debrided did well, right? Getting rid of that fungal bioburden, that fungal load. So here are some pictures. Now, again, there was methylene blue placed on these nails for the before doing the photodynamic therapy. So that's why some of them have some blue staining, right? That's not nail polish. So if you take a look at the baseline, this is our typical nail at 6 months. You can see the change. Same thing here. So just going across baseline to 6 months, this nail here, it's a beautiful nail going from here to here. And this nail even has disappearing nail bed. So this nail did have fungal elements with a disappearing nail bed. And again, the nail isn't going to be able to grow that much forward, but the nail has, the visual part of the nail is improved, right? So here we have a nice streak, and the streak is gone, right? It is no longer streaky. We have, again, this nail to this nail, this nail to this nail. So again, you can take a look at the success in this particular trial. But what about nail psoriasis? Because, like this lecture was talking about all the different things that can happen to nails. And I did mention nail psoriasis and onychomycosis together, actually. Well, this is something I've actually done. Looking at, as I mentioned, photodynamic therapy can either be done with an LED light or a laser light or not a laser light. This was using pulse dye laser. So the photodynamic part of it was pulse dye laser. And they used methyl aminolevulinate, MAL. I actually use something different, but again, it's one of those things where it's the combination of something, right? So they had 61 nails treated with photodynamic therapy and 60 nails done with pulse dye laser among 14 patients. Again, MAL was used as the photosensitizer using a bioadhesive patch. There were no statistical differences found between the two, so it could go either way. I used tazarotene. That's what I had used, tazarotene with pulse dye laser. It additionally, like, it didn't significantly change the nail result, what we call NAPSI, which is the nail score results, but a significantly higher percentage of patients had improvement after 6 months of treatment with topical tazarotene plus photodynamic or pulse dye light than after tazarotene treatment alone. And prior to using that, I had done tazarotene alone. So it's one of those things where light plus some sort of sensitizer can make such a big difference in these patients. And imagine if you have somebody who has onychomycosis and nail psoriasis, again, you can certainly impact the onychomycosis and then eventually help with the nail psoriasis as well, because nail psoriasis is a real tough one to treat. Oops. All right, this was my old license plate. I don't know if I'm actually that fun, but I am a gal. Put them together. I'm a fun gal. I'll leave that for you to decide. But ultimately, I hope this was interesting to you. Biomechanical nail disorders, we want to make sure that we rule out onychomycosis, right? And knowing that not all nail disorders are fungal. And when we do have fungal nails, we want to be able to have treatment options for patients. One of the things I love about clinical practice is that patients never fit into a box, right? And they all have different needs and wants and expectations. So it's nice to have a lot of tools in your toolbox for patients to experience. I'll stop my share.
Thanks, Dr. Vlahovic, for your wonderful presentation. Now we are open for questions. Please write down your question in the Q&A or the chat, or you can even raise your hand. Okay. Dr. Steins is asking, do you have a preferred test? PCR?
I end up doing a lot of PAS and GMS, but again, if there's people who do PCR, I mean, it's whatever you feel comfortable with.
Uh, we have another question. How do you treat diabetic fungal nails that involve all 10 nails?
Well, it depends on the severity of the presentation, right? Is it mild, moderate, or severe? How many medications is the patient on? What's their polypharmacy? Um, what what else is going on with the patient, right? So it to me, it's you know, there's it's going to really depend on, is this patient an oral antifungal candidate? Are they a topical antifungal candidate? Is that something that they prefer? They don't want to apply anything? Or again, could they benefit from something like photodynamic therapy where they don't have to worry about any pharmacy at all?
Dr. Friedman is asking when the FDA approve it.
If you're asking about the TOEFX, so 2 years ago.
Okay, we have a few more. The patient ultimately wants the doctor to tell them what to do. So what do you tell them?
I often will try to put myself in their place, right? Again, I'm looking at the whole patient. Are they someone who drinks alcohol? Are they someone who doesn't want to physically apply anything? Maybe the pill is the better option for them. I have patients come in who are the opposite. I do not want another pill. Then something that is outside of them is the better option. So I try to think about where they're coming from, what the whole clinical picture is. And the thing is that to me, I've seen it in all different ages, where I surprisingly had in my current position, I've had 80 and 90-year-olds who want their nails treated with an antifungal. I'm like, wow, sure, okay. I mean, you have the right constitution. I can give you an oral or something, again, topical, that's fine. So it's to me such a patient to patient thing. And just going by my experience of saying, you know what, I think if it were me, I'd choose this. But what makes you feel comfortable? Are you okay with taking a pill? Are you okay with something being applied outside of you? Like what are your thoughts? Um, are they someone who has a spinal stenosis and they can't reach their feet? Or are they someone who, if they can't reach their feet, do they have anyone to help them? And again, it's just to me such a patient to patient basis type of thing.
Dr. Moore is asking, can you use toe effects on patient with history of skin cancer on the toe?
Um, while there is no known contraindication, um, because in the serum we have a combination of few ingredients, one of which is methylene blue, but also other ingredients. Um, I don't see a problem. However, when we get this question, I always recommend to consult with the oncologist or the physician that treating this case, just to make sure that this is the right thing to do. Tracy, any comment?
Yeah, I mean, there shouldn't be there's no contraindications that I can think of, but I think it's always wise to speak with the treating physician, whether that's the oncologist or dermatologist.
And also, there is no indication of the formula to go into the bloodstream. It's a local treatment.
If the patient has a chronic pulmonary disease, it is recommended to use is it recommended to use TOFX? He is a diabetic with some PVD.
It's
Uh, Dr. Van Ham, I think.
Oh, okay.
Yeah.
Can you repeat the question again,
Yes,
please?
yes. So if the patient has chronic pulmonary disease, can they use TOFX on that patient? And this patient is diabetic with some PVD.
Um, I don't see any issue why, and it's very also safe to use it on diabetic patients. Um, However, diabetic patients have other issues, neuropathy. They don't feel any pain. The debridement should be um, do with very carefully, but I do not see any issues with that. Maybe
Yeah,
Tracy
and what
can.
we're concerned about with PVD is obviously blood flow, right? So something systemic is not going to be the best thing for that situation. You would want something that's outside of the body, if if they even want to get it treated, right?
I also wanted to add about that, but diabetic and possibly if they have pressure wounds or diabetic wounds, so um, there are some information and also some papers about photodynamic therapy that is working very well for wounds. Also, some of the clinicians are using TOEFX at the moment off label and it's working very well for wounds. And also, we are going to start a study about using similar technology for wound treatment.
Yeah, I don't see any issues in using this in a diabetic patient
Right.
at all.
We have another question. If the patient has onycholysis due to a severe onychomycosis and has some PAD and is not able to take oral antifungal, will be recommended TOFX. Like,
So again, with PAD, it's the problem is that you're always concerned, is Onycho really the most important issue that they have, right? Like to me, it's more about revascularization, making sure that they are getting some perfusion, that they don't have any ulcerations, things like that. So, whatever is the most pressing thing should be treated first, but certainly you wouldn't want to give them a systemic antifungal for their nails. You again would want something that is external, but with the caution that again, if they don't have a lot of good perfusion, they may or may not have success, right?
I have a related question. So, if what would you do if you see a case, because we see those a lot with onycholysis and onychomycosis? So, would you resolve or disappearing nail bed? So, would you resolve which issue would you? What's the orders of treatment?
So, disappearing nail bed, again, it's
Yes.
you can't fully resolve that unless you do either some sort of surgical procedure or just like tell the patient this is what your nail's going to look like. Um, with on, as I was mentioning before, onycholysis can be traumatic, right? From biomechanical trauma, or it can be from onychomycosis. So onycholysis from onychomycosis that can resolve. But with trauma, you have to figure out what that trauma is. Is it coming from a hammer toe? Is it coming from a steel toed boot? Like, what is the source of that trauma? Or is that, again, trauma related to nail psoriasis? Because nail psoriasis will cause that onycholysis too. So, if it is related to onychomycosis, then that is something that can be managed when you treat the onychomycosis.
Super interesting what you explained about disappearing nail beds. I didn't know that because it's exposed to oxygen.
Yeah, it's meant to be covered. The nail plate is meant to cover that nail bed. It is not meant to be exposed.
Um, Another question, how does TOFX compare with pinpoint laser infection resolution wise and number of treatment required?
Um, so we didn't compare it one to one to pinpoint laser, but I can say that um, in essence, lasers treatments are a mode of action is heat and burning sensation may occur. The results are varies because it's the different intensity. With pinpoint laser, it's almost impossible or very, very difficult to treat all the nail plate unless you have a system where you don't miss any area. So this to me it's very challenging to really eradicate all the infection. And did I miss any of them?
Well, and can I add that, technically you need a 60 degrees Celsius temperature to kill a
Yes.
dermatophyte, and patients aren't going to tolerate that if heat really is the modality. Because like with laser, it's so hard because of the physics of the nail, right? So that's the main difference between photodynamic therapy and laser is laser, it's just like brute force heat killing. If you can even get close to the temperature that's going to not necessarily kill the fungus, but maybe stun it. Whereas with the reactive oxygen species, that is known to be, it's an antimicrobial. So, and the reaction is only going on as long as the light source is on.
Right.
So it's a finite thing, and it's not going to feel even like a laser at all.
There are a few clinicians that use laser at the proximal edge to increase blood flow. And then they use it in combination with TOFX. Do you think it's a valid assumption?
Um, Not necessarily. I don't necessarily agree with that, but again, everybody has their own way of doing things, so I'm not criticizing them. It's just not something I would choose to do.
Okay.
The next question is methylene blue the photosensitizer? And what light source do you use for PDT?
So yes, it's the with TOFX, it's the photosensitizer that we're using. We also combined with botanical extract that has antifungal and antimicrobial properties, and also solvents that stabilizes the methylene blue because it can be a dimer, which is two molecules together, and you want it as a monomer because it's more active. Also, we found a way to really help the active photosensitizer to penetrate into the nail bed.
The next question is any contraindication in pregnancy or specific skin sensitivity or PAD?
There is no sensitivity. The only sensitivity that might occur with using methylene blue, again, not from our clinical studies, just from the literature. So methylene blue might react with an enzyme, so G6PD. So if a patient has the G6PD deficiency, which is kind of rare, they might have allergic reaction on the skin, and you should just test it before applying the technology. It's just a patch on the skin.
Do you quote a percentage chance of clearing with a certain treatment?
Again, can you repeat, Redita?
Uh,
Yeah.
the doctor is asking, do you quote any percent of chance of clearing the nails with certain treatment, like certain treatment? Maybe the doctor is asking, like, what is the chance percentage of like efficacy rate?
So the efficacy with toe effects, according to our clinical study, is 73% clearance and 59% mycological cure on mostly severe cases. So we treated 92% severe cases.
The next question is, does the TOEFX penetrate down to where or microorganisms live in the nail bed?
Yes. So we did it in such a way that the serum, the formula, has a low surface tension, and also we have a carrier, so it's drag the formula into the nail bed where the fungus resides. And also we're doing a combination of dual wavelengths, so the blue wavelength does not penetrate the nail plate. However, the red penetrates up to 6 millimeters, so it can penetrate the epidermis. And actually, when you put the toes under the light, you can see that the light travels, the red light. So the combination of red light that travels and the formula that penetrates well, so it's reached the infection, could be dermatophytes or others where there resides in the nail bed.
Can blue dye be washed off between the treatments?
Sorry?
Can blue dye, I mean the serum, the blue color of the serum, be washed off during in between the treatments?
Yes, it will be washed off.
Uh, is it covered by insurance? If not, what is the cost to a private clinic?
Um, it's no, it does not cover it by insurance. It's a cash service, and you can contact us to get the cost. We have, I think, we have a promotion for this conference, webinar attendees.
Okay, we have a few more questions. Uh, how do you treat culture positive yeast infection of the nail in a healthy patient?
So the thing is yeast may or may not be the actual source. Typically when we attack a yeast, it's with an azole. But in my experience, the dermatophyte is what started it. And we can have molds and yeast kind of come on afterwards. So important to realize that the yeast may or may not be the actual inciting pathogen. It might be a dermatophyte that's just kind of overcrowded by a yeast.
Uh, that's all the questions we got for tonight. And Alexis, Dr. Alexis is saying, fantastic webinar. Thank you again from Sleepy UK. And she also had another question, is TOEFX available in Europe?
Yes, you can answer. Yes, it's available in the UK.
It is available in the UK. We have multiple practitioners who are using the TOEFX system in UK. Thank you everyone for joining us tonight. It was a wonderful session and we learned a lot, Dr. Vlahovic, tonight. And thank you. Enjoy and good night.
Good night.
Bye. Thank you.
Thank you.
Bye.